Olá, boa noite. Eu sou Eduardo Millen, cirurgião de mama, cofundador do grupo Câncer de Mama Brasil. Tenho o prazer de ter aqui comigo Francisco Pimentel, cirurgião de mama, também fundador do grupo Câncer de Mama Brasil. E essa noite a gente tem um convidado super especial, que é o Michael Alvarado. Michael, ele é cirurgião de mama da Universidade da Califórnia, São Francisco, e já esteve aqui conosco diversas vezes. A gente, obviamente, preferia tê-lo presencialmente, mas em função dessa pandemia, a gente resolveu ver como o Michael anda fazendo as coisas em câncer de mama em São Francisco. Então, o Pimentel vai apresentá-los e nós vamos começar algumas questões para o Michael. Obviamente, as questões estão abertas para o público, a gente preparou 3 casos e um cirurgião enviou um caso para a gente apresentar. Michael, you are our special guest, and we would like to discuss with you tonight. It's a great opportunity to hear about breast cancer and COVID. Pimentel will guide this live, okay?
Okay.
Hi, Michael. How are you?
Good. It's a pleasure to be here. Thank you all so much for setting this up.
Thank you for joining us tonight. So, what time is now in San Francisco?
It's about 4 o'clock in the afternoon.
So, the big question is, how are you dealing in San Francisco with this pandemic of COVID-19?
Yes, so as you know, in the United States, there's been some significant hotspot in New York. And New York has been very, very difficult for patients, doctors, families, etc. Here in San Francisco, in California, we so far have been very lucky that they closed down the city pretty early to try to avoid the same situation in New York. So we've been very lucky, for example, in our hospital, which is very busy, major hospital in San Francisco. On average, we only have around 25 COVID patients in the hospital, and we've only had about 10 to 12 in the intensive care unit at any one time, and only about half of those have been ventilated. So it seems like closing down the city and really paying attention to social distance and limiting interaction, we've kept the numbers very, very low. Now, what that means is that we've also tried very hard in the hospital itself to limit the possibility of infection coming into the hospital. And so we, similar to other institutions in the country, have really taken part in moving all elective cases farther down in time to try to avoid not only utilization of the ICU or blood products or protective personal equipment, but also to decrease the chance of bringing the infection into the hospital. So we have been now for about 9 weeks limiting the number of cases to a very, very, very low number. And we're just starting to open up to do more elective cases at this point.
So you are postponing treatment like in hormone positive cancer, you're recommending like neoadjuvant hormonal therapy?
Correct. So I think broadly in 2 groups of patients, there's the invasive breast cancer and the in situ cancer. For the in situ cancers, probably upwards or near 90% are getting offered some type of surgical therapy no earlier than 3 months from diagnosis. Now, there are some exceptions for women that are young age, under the age of 45, or women that have palpable DCIS that's high grade and potentially estrogen negative. Those we were taking to surgery more or less immediately. However, as you know, the number of women with palpable DCIS is very low, and the number of young women with estrogen negative in situ is very low as well. So it was only a few of those patients that were going to surgery. Otherwise, the DCIS would be given anti-estrogen therapy and planned for surgery 3 months later. For those women with invasive breast cancers, we would utilize a lot, if possible, as you stated, neoadjuvant therapy. So if they were HER2 positive or triple negative, all those patients went on neoadjuvant chemotherapy and targeted therapies. If the patient was estrogen positive and lymph node negative, those patients were put on hormone therapy for a minimum of 3 months and then reassessed. But I will say that the estrogen positive patient that was node negative, we are also ordering a genomic assay to get a better idea of the biology, because if they were very, very low, then okay, they go on estrogen therapy for at least 3 months. If they had a very high mammaprint or oncotype, then they would go on chemotherapy. It was the patients in the middle where we really weren't sure what kind of chemotherapy they might get, that we might take those very few patients directly to surgery. But we really did bring it down to a very small number that were actually taken to the operating room during the last 8 to 9 weeks.
So what about big case? When I have a mastectomy, you perform immediate reconstruction or delay?
Correct. So as you know, and the listeners obviously know, that most of our and most of your mastectomies, we're all doing nipple sparing mastectomy. And it's very difficult to not do some type of immediate reconstruction and preserve the nipple, especially when we don't know what would be the time frame to be able to come back to do something. So just like you said, if the patient was wanting autologous or a deep flap, they would only be offered a tissue expander as a holding place. So they would get their mastectomy and the tissue expander would be placed, and then they would have to wait until it seemed like it was safe to do the autologous or deep flap. But we felt strongly that we could still do tissue expander and not increase significantly the amount of blood loss, and would not significantly increase a large amount of time in the operating room, and it would be given the women the best opportunity for the best cosmetic outcome.
Are you offering tests before surgery for these patients?
For the COVID test?
Yeah.
So that's a great question. I'm sure you've seen in the news that the United States has not done a very good job with testing or being prepared for testing. That has been a significant issue, and it may be hard for people to imagine. It's hard for myself and my colleagues to imagine because we're here, but we're just now, within the last week, are starting to test our patients before going to surgery, because the 8 weeks before, there was virtually no opportunity to get those done in a timely fashion because there wasn't enough testing kits to do for these elective patients that had no symptoms. But now the strategy is exactly like you say. So all patients now who are going forward to have surgery, they get tested 3 days before surgery. The test usually comes back within 24 to 36 hours. If they're negative, they go forward with their surgery. If they're positive, we decide, does the patient need an emergent surgery, which is unlikely for breast surgery cases. So those would definitely be delayed. So we just implemented, everybody gets tested before they go to the operating room, if at all possible. But you can imagine, similar to Brazil, that many people live outside of the city and come from a distance. So now the difficulty is trying to find testing centers outside of the city that are reliable, so patients don't have to drive or take transportation all the way into the city, get the test, go all the way back home, wait another 3 days, and then come back into the city. So we're now trying to identify testing centers localized in areas outside of the city. But you're absolutely right. Testing is crucial. And I think moving forward in other places of the world, especially in the Southern Hemisphere, as the weather changes and it becomes more like flu season, this is going to be very, very important to have testing for patients.
Just one more question before you go on the clinical case. Do you have any experience in patients that you have surgery and they were infected by COVID, about the outcomes after surgery?
So far at this institution, we've been very lucky and we have not had any. But there are reports in the United States that people that have COVID unknown, that have surgery, have a potential worse outcome that has to do potentially with the anesthesia itself. I don't think they've determined what it is, but for whatever reason, anesthesia and the infection has a decreased outcome that is beneficial for those patients. But we've been very lucky that we have not had that so far at this point.
So I think you go right now to the clinical case, Millen, please.
Yes, okay. Michael, we will start with a case sent by our colleague, Eduardo Bruno from Rio de Janeiro. This is a patient with 43 years old. She has a T2N1 invasive ductal carcinoma with estrogen receptor negative, progesterone receptor 2%, HER2 negative, Ki67 30%. She was submitted to a neoadjuvant chemotherapy until last month. At physical examination, she has a nipple retraction. Oh my God. They decide to do a skin-sparing mastectomy with tissue expander, and at frozen section, there were two negative sentinel nodes. At final pathology, it was an invasive ductal carcinoma, grade 2, 3.5 centimeters, and 2 sentinel nodes, one of them positive at macrometastasis. The final pathology was a PT2N1A, and the immunohistochemistry was a triple negative breast cancer after neoadjuvant chemotherapy. The question is, in the COVID scenario, would you do axillary lymph node dissection during this pandemic, or would you wait to perform surgery? Is there any other option? They advise that radiotherapy is planned in this case. What are the options that we have to this case?
Yeah, so this is one of those very difficult cases where you think everything is negative, and then you find the positive lymph node out back. I think even outside of the COVID time period, it's a very interesting case with regards to axillary dissection versus radiation for control. There are obviously clinical trials that are happening right now to try to answer the question, in these types of patients, do they actually need both axillary lymph node dissection and radiation? Now, as you know, and as the listeners know, there really is not a lot of data to suggest that axillary lymph node dissection benefits this patient with regards to overall survival. There might be a small benefit in terms of local regional recurrence, But for a woman that has triple negative breast cancer and does not have a complete pathologic response, most of her risk is going to be systemic with distant recurrence. So it's difficult here because you really need to weigh what is the risk associated with dissection of the axilla plus radiation. Now, I would say that this patient, at least in the United States, would get offered post-mastectomy radiation 100% of the time. So I think it's pretty standard. Adding the axillary node dissection increases the risk of peripheral lymphedema with potentially no significant survival benefit. So I think even without COVID, I would initially talk to the patient and tell them that I don't think that they absolutely have to have the axillary node dissection. I think that they would probably do well with radiation. They would be having close follow-up. And if they were to have a recurrence, we would know that and we could go back at that time. But it would be a discussion that would be put up for them. Now, in this era of difficulty of having patients come back to the operating room, especially for something that may not have a benefit, I think we would probably, at our institution at the university here in San Francisco, our radiation oncologists feel very strongly that we can have the discussion about omitting axillary node dissection in somebody who has a micromet, even knowing that there may be some residual microscopic disease in the lymph nodes. And so we would feel very comfortable offering that patient radiation only and not doing the dissection.
Okay, Michael, we agree. Pimentel, we have some questions about the audience. Fabricio Brenelli is asking, what type of testing do you are using to try these patients? EGG, EGM, PCR, what are you doing before surgery?
At this time right now, we're only utilizing the PCR test.
Yes. And Josebine is our oncologist. What's the evidence behind genomic testing before surgery for HER2 positive disease?
That's a great question, and I apologize if it made it sound like you should get it. So absolutely right. There is no evidence to utilize genomic testing for HER2 positive disease right now in the clinical setting. As you all know, there is some very interesting data utilizing the 70 gene assay and looking at the different subtypes and how often the HER2 positive might behave more like a luminal cancer. I think that's very interesting information that maybe could be utilized in a clinical trial someday, but you're absolutely right. If a patient is HER2 positive, we do not order a genomic test. They get treated as HER2 positive patients.
Okay. Michael, about axillary dissection, I think that's time really to think better before to perform axillary dissection. I know that we are waiting for these trials, but we can discuss individually in any case because you show that the lymphedema and the complications when you use axillary dissection and radiotherapy is the worst problem that I can have treating breast cancer. So we discuss the next case, okay, Pimentel? I'm not hearing you.
I think he's on mute.
Yeah.
Okay. If this case was a hormone positive cancer, you're gonna proceed in the same way, not axillary dissection?
Correct. I think that's some interesting thought process as well, because there are obvious papers that have been published looking at response to radiation, both estrogen positive and estrogen negative. But for our cases, irregardless of the receptor status, we still have the discussion about omitting the axillary node dissection. Specifically in these cases where there's minimal disease in one lymph node and at least one other that's negative, and the patient did not have bulky adenopathy before neoadjuvant. So it really is the patient that has maybe no identified positive node before, or a small amount in one lymph node before surgery that they get neoadjuvant therapy. But you're right, we don't specifically change our recommendation based solely on the receptor status. And I think logically it makes sense. I think if we go back to kind of just the whole Z11 concept, when we do lumpectomy for patients in sentinel node, if they're HER2 positive or estrogen negative or estrogen positive, they all get the option for being a quote Z11 patient in omitting dissection and going on to radiation. Now I know people will say that's different, that's lumpectomy, but I think in the mastectomy setting, I think we can have that same thought process.
Okay. We have many questions. Maybe we discuss this after. Let's try to see another case. This is a 34 years old. She noted a lump in her left breast. No clinical or surgical comorbidities, and she has no family history of breast or ovarian cancer. But paternal grandmother has pancreas cancer, and maternal grandmother has renal cancer. She has a medium-large symmetric breast and a fixed 3 centimeters nodule in inferior inner quadrant. No axillary or supraclavicular lymph nodes. At mammography and ultrasound, she has a 2.6 nodule with irregular margins located in the left inferior inner quadrant. At mammography and ultrasound, no axillary lymph nodes suspect, and they was classified as class 4. This is the image for ultrasound, a irregular nodule with microlobulated margins. And we decided to do a ultrasound-guided core biopsy. She had an invasive ductal carcinoma, grade 2, triple negative with Ki-67-8%. We decide to do.
Millen.
Yeah.
I think the Michael could comment before the MRI about the case.
Okay.
Could you comment?
Yes, I think this would be, the perfect example for a patient to undergo neoadjuvant therapy based on the triple negative aspect of this and her age. Obviously, she's going to get offered chemotherapy regardless. At our institution, this patient would get offered anthracycline-based chemotherapy as well as taxane, and the lymph node status would not change that. So I think this would be a great patient to have the neoadjuvant therapy and look at the response to therapy to get information about what her prognosis would be.
Okay. MRI. At MRI, we can see more than one nodule. The anterior nodule is located 2.6 centimeters from the nipple, and the posterior one 0.4 centimeters from the pectoral muscle. There is no lymph node suspected, and we asked her to do a multigenial panel that was negative, but we found 3 VUS at APC, BARD1, and PALD1. Michael, how do you stage these patients at San Francisco? Do you use PET? She was a T2 in 0 multicentric breast cancer.
Yes, for this patient, based on the imaging so far and the clinical exam, she would not get any whole body imaging at this point. She would get referred to the oncologist, and they would discuss neoadjuvant therapy and potentially clinical trial if it were open. And then typically she would go on chemotherapy at this point.
Okay.
Michael, I have a question, Millen. Michael, it's a case of multifocal or multicentric disease. Would you recommend another biopsy for the other tumor to roll out another molecular subtype?
Yeah, great question. I was hoping that you would bring this up. So I think a couple things. My first reason for doing the second biopsy. So yes, I would recommend the second biopsy specifically if the patient was interested in breast conservation. A couple reasons. So sometimes the surgeon might say to the patient, based on the MRI, the area is going to be too big and you need to have a mastectomy. But if you don't have confirmation with pathology, what happens if you do the surgery and you realize that, oh, actually, it probably was much smaller and you could have had breast conservation? So I think that would be a terrible thing. So I think if the patient is interested in breast conservation, then I would get the second biopsy to know the extent of the disease. Now, it's possible that this could be a different subtype. It's unlikely, but you're right. You would also get information about subtype. And then finally, some people, when you look at the area of that, some people would say, well, regardless, even if that is positive, then she cannot have breast conservation because the area is too big and she has multicentric tumors. But there is pretty good data. It's retrospective, but there is a paper that came out that looked at the 3 large neoadjuvant trials, the JPARD trials, I think Quarto, Septo, and Sixto. I can't remember which 3, but the 3 neoadjuvant trials in the JPARDs with almost 6,000 patients. And when they looked at outcomes for multicentric versus unifocal, there was no difference in local regional recurrence when people had breast conservation. So as you all know, we used to say always multicentric, you need to have a mastectomy. But now I think there's starting to become better data to show that women with multifocal or multicentric tumors can potentially have multiple lumpectomies and then whole breast radiation. And actually radiation oncology can actually boost each of the lumpectomy cavities. And that's been shown in the International Journal for Radiation Oncology, the Red Journal, for an ACOSOG trial, where the ACOSOG trial was specifically looking at multiple tumors removed with lumpectomy. Now, we haven't seen the outcomes yet, but it did look to be feasible, and radiation oncologists were able to boost each of the tumor beds specifically.
Michael, we discussed with her about another site of biopsy, but she has only 34 years. And we discussed that the risk of recurrence with multicentric disease and the young age is higher than if she has 60. So she preferred not to biopsy, and we decide after with genetic test negative to after the chemotherapy perform nipple sparing mastectomy. So it's just because we haven't biopsied the area. Okay?
Yeah.
But we
Michael,
order here
Millen,
to
let me make another question for Michael in this theme. Michael, even if you perform a mastectomy, do you think it's important to localization the tumor before surgery to help pathologists to see the tumor, because right now it's very important to identify residual disease? Do you do this in San Francisco?
Yes, that's a very good question. We have had that discussion about finding the tumor bed after mastectomy, especially after neoadjuvant therapy. And we have discussed placing clips at the different sites, like you say, even if the patient is thinking about mastectomy, because what we can do then is an x-ray after the surgery so that they can find those sites specifically. We have not implemented it in every patient, but we have done it in a few patients. So I think it depends on your pathologist and how confident your pathologist is in finding those areas after the surgery.
Okay. Michael, this patient had a PET scan that showed that she had a multifocal breast, axillary, and inner mammary lymph node with survey the 5.4 at axillary lymph node and 4 at inner mammary lymph node. She received 4 cycles of advermectin and cyclophosphamide, and after 2 cycles of Taxol, she had a neuropathy. She had a permanent paresthesia that interferes with her daily activities and mobility limitations, worse after the 2nd cycle of Taxol. So, this is our patient. I received her last week to decide what to do with her. When we planned the surgery, there is no COVID, no pandemic, and she was decided to visit a plastic surgeon and asked him to do a bilateral nipple-sparing mastectomy. We discussed a lot that no beneficial in overall survival, but she, in that time, preferred to do a nipple-sparing mastectomy. And now this is the situation. She has 34 years old, a complete response, clinical and radiological at MRI, and we have to decide her surgery. There is no time to wait because she finished the last cycle of chemotherapy 2 weeks ago. And is it time to do nipple-sparing mastectomy, bilateral nipple-sparing mastectomy with reconstruction in this time of COVID? Mm-hmm. Only one observation. The hospital that I work here in Rio, we are testing every week all the surgical team and the patients. And if the team or the patient has PCR positive, obviously we postponed the surgery 2 weeks later. Mm-hmm. So the question is, the patient, we haven't clipped the node because it was multicentric, and we decide to have a bilateral nipple-sparing mastectomy. What you want to do with these patients, maybe at San Francisco?
Yeah, so this is obviously difficult when patients can't finish their chemotherapy, and we don't have much choice other than to take them to surgery. I think at this point, the important aspect, and this would have been, our reasoning in the last 6 to 8 weeks, if we'd had the testing, that's great. Then we can be sure that we're not bringing a positive patient into the hospital. But at the same time, it's difficult because she doesn't have any other options. But during that time, we would have only offered her a unilateral mastectomy with a tissue expander placement, because at the time, we were very concerned about the amount of time in the OR, the blood loss potentially, and things like that. So it was more about utilization and risk of problems that would potentially lead to overuse of supplies, overuse of blood products potentially. So we would have offered her unilateral mastectomy. Now it depends on each institution. If it seems like there's no problem with the personal protective equipment. There's no problem with blood products. There's no problem with utilization of space. Then I think it would be fine to offer her the bilateral nipple-sparing mastectomy with reconstruction.
Okay. It was our decision too. And in second time, when she changed the sponsor for prosthesis, he can do the other breast if she really wants.
Correct.
Pimentel, we have some questions about the audience. Fabricio is asking if we have to test MLPA because he's thinking that she did only a NGS. Fabricio, she did a in vitro test with 84 genes. I don't know if we need MLPA. She had a genetic counseling that it's for her. It's good. This. Pimentel, could you read the other questions? Or we can follow with another case. What do you prefer, Michael?
Whatever you decide. I'm happy to do the next case if you want.
Okay. Let's try. This is a case that a patient with 36 years old, her sister tested positive for ATM pathological mutation. She's pregnant now with 26, 27 weeks. At the physical exam, she has a medium large breast and no axillary or supraclavicular lymph nodes. Mammography, there is no node at palpation, but mammography, several clusters of microcalcifications at the central portion of the right breast. Breast ultrasound by HIDES 1. This is the image. We can see this focus of microcalcifications, another here, and a calcification. I don't know that it's a microcalcification close to the skin. It was proposed for her a mammectomy, but it was done a surgery because the security not allowed the mammectomy. This is the Brazil. We have different scenarios, and for this patient, she was submitted a surgical biopsy. This is not a case in Rio. She has a ductal carcinoma in situ, 1.2 centimeters, free margins, high grade, estrogen and progesterone receptor positive, HER2 negative, KI 30%. One foc of microinvasion at immunohistochemistry. She had his birth at the early April, and the question is, OR, time to radiotherapy, management of genetic risk, and if she really needs a sentinel node biopsy as she had a microinvasive cancer.
Difficult case, obviously, with the pregnancy. I think in general, young women under the age of 40 with palpable DCIS that's high grade, there's something special about these cases, something that the biology, I think, is very, very different than your normal or usual DCIS. And these are the types of cases that I think make us very nervous. We're lucky that almost all DCIS, you never hear about recurrences in the axilla. You don't hear very much recurrences distant. But when you do hear about a patient that had, quote, DCIS only, and then now shows up with bone metastases, it's usually the patient like this that has high-grade DCIS that's palpable, young age, with a tiny dot of microinvasion. So I think, as you all know, our group is very forward thinking in doing less for DCIS. However, in cases like this, we really feel that they probably do benefit the most from the different adjuvant therapies. And I think this patient would definitely need to have a counsel about adding radiation. And it's difficult because we always want the mother to be able to breastfeed for as long as they can, because we know that there are benefits to that. But I think in this case, we would definitely talk to her about potentially not breastfeeding for more than probably 4 to 6 weeks, or maybe 4 to 6 weeks, and then stop breastfeeding and then go on to radiation maybe 6 weeks later, to try to get in that window of opportunity, the radiation. Now, having said that, she may decide, and again, it really is a personal preference, if the woman decides that breastfeeding her baby is more important than keeping her breast, she could potentially breastfeed for 6 months and then potentially have a mastectomy with reconstruction. Or, of course, she could potentially do no radiation, but I think she would have a very high risk of local recurrence. And then the last thing I'll say is that, again, adjuvant endocrine anti-estrogen therapy for DCIS typically is for prevention of another or new breast cancer. But I think specifically in patients that are high-grade, young age, palpable DCIS, I think the anti-estrogen therapy is more of an adjuvant therapy for this DCIS more than a prevention. I really do think that these women probably benefit from this as a possibility for decreasing the risk of distant recurrence. Again, it's probably not that high compared to pure invasive breast cancer, but I think these are the ones that make us very nervous.
Okay.
I think Pimentel is muted still.
Pimentel. Michael?
Yes. Hello.
With my, I think that, no, okay. Okay, Michael.
Yeah.
Pimentel is not with us?
Okay.
Okay. Her sister has an ATM positive mutation. If she decides to do now the radiotherapy, maybe if she needs a nipple sparing mastectomy after, this should be a difficult surgery.
Yeah.
In Brazil, we are studying to delay radiotherapy, and many centers are trying to do the fast protocol to radiotherapy. Are you using it at San Francisco?
We are utilizing that protocol, but in a very small population, more women that are postmenopausal for grade 1 lymph node negative tumors that don't require chemotherapy. So we are utilizing it, but it's a very small population. I think in this patient, we probably would not offer it because of her young age and palpable DCIS. But the ATM mutation in the sister is obviously important because I can't remember, this patient did not get tested with...
No.
Right.
So I think that we have to test this patient, maybe delay the radiotherapy, and we will have the time, 2-3 months, to decide if we trying to do a nipple sparing mastectomy or to only radiotherapy, right?
No, I agree. I agree. It's a very difficult, situation, obviously, but these are the ones where we have to give the patient the best information we have and help them come up with the best decision for themselves as well. So it's a very difficult one.
Okay. We have some problems with Pimentel. I don't see Pimentel. Okay, let's try to see another case. This is the last case from Belo Horizonte. Patient with medium symmetric breast, normal breasts at physical examination, no axillary or supraclavicular lymph nodes. Case 3. No. Yes, a 74-year-old patient, asymptomatic, mammographic screening. No normal physical examination, and a discrete lump in the upper outer quadrant of her left breast. At ultrasound, 1.3 centimeters lump in the upper outer quadrant of her left breast. No suspected lymph node in axilla by HADS 4. She had a core biopsy and a ductal invasive carcinoma, 1.5 G3. Sentinel node, 1 sentinel node with macrometastasis, 10 millimeters, and extracapsular extension, 3 millimeters. She had the estrogen and receptor positive, HER2 positive, and Ki67, 30%. The questions: axillary radiotherapy or axillary dissection? Do you use molecular profile to discuss adjuvant treatment for this woman? Remember that it was a 74-year-old woman that had the mammography screening.
Right. So it looks like it's a T1 tumor with a micromet.
Yes.
With a small amount of extracapsular extension.
Yeah.
So I think there were patients in Z11 that did not have dissection, even with a small amount of extracapsular extension. I think we're getting feedback on somebody. There we go.
Yes.
So this case, we would offer them the oncologist appointment to talk about systemic therapy. So we would not do any genomic profiling because she's HER2 positive. She would see oncology and probably discuss a taxane-based chemotherapy regimen with targeted therapy for HER2. We would not do the axillary node dissection typically, but she would get whole breast radiation with axillary radiation.
Okay. And if this patient had a HER2 negative, maybe you discuss with her a molecular profile.
Yes, if the HER2 was negative, I think we would definitely order the molecular assay because in both both of the top molecular assays that are used, both the MammaPrint assay and the Oncotype assay, both of them show that a very large proportion of grade 3 tumors end up being low risk. Probably 20 to 30% of those grade 3 tumors end up being low molecular risk.
Michael, only to clarify, I think that some colleagues that they are thinking that we decide to do radiotherapy and not to do axillary dissection, think that we are in pandemic era. But I know that you usually do this, and when you decide to do today axillary dissection, many surgeons are doing axillary dissection because they are finding extra capsular extension, because in Z11 they used this criteria for exclusion. So many things changed before Z11. Many papers show that extra capsular extension is not an absolute indication for axillary dissection. It's not because we are in pandemic, but there is no benefit to do axillary dissection in small extracapsular extension.
Correct. I completely agree with you that even before the COVID pandemic, this patient in our clinic would typically not get an axillary lymph node dissection. They would go to radiation, both whole breast and axillary. Again, as you stated, there really is a lack of data to suggest that axillary node dissection is beneficial. It's just that we've done it for so long, people think we have to do it. And as you know, there are the clinical trials right now looking at different aspects of omitting axillary node dissection in patients and utilizing radiation.
Okay.
But I think what's key is that I look at these newer clinical trials in a different way. So these trials are set up by some people to see, can we omit or can we stop doing axillary node dissection? Will the clinical trial tell us that we can stop doing it? I look at these clinical trials in the opposite direction. Will these clinical trials tell us that we need to do the dissection? So from our standpoint, our standard of care is typically not to do the dissection, and we will await these clinical trials to tell us if we need to do the dissection.
Okay. Well, we have some problems with Pimentel, and we had now a downgrade of our speaker. So Guilherme Novita is coming to substitute Pimentel, but we are lucky because he is mute. Guilherme, try to turn on your microphone, please.
Professor Novita, get one of your children to help you with your computer.
Novita, so we have to see him and we can hear. I think that we have many questions about our audience. Let's try to see them. Lincoln Murray, in TN case underwent to neoadjuvant therapy. If you don't have PCR, we can give chemotherapy or systemic treatment like a CREATE trial or other before surgery, residual tumor.
Correct. Exactly. So if there is the possibility of a clinical trial, we definitely would use the clinical trial for residual disease, and we have done that in the past. So if we have a clinical trial open for residual disease after neoadjuvant therapy, absolutely, we will enroll those patients if they're willing to do the clinical trial.
Okay. Renato Torresan from Campinas asking us if you agree with the latest recommendation of ASBR to perform the genetic test for all of breast cancer patients, even the older ones.
Correct. So this is something that's changing dramatically, as you all know. Dr. Pat Whitworth, for example, and others have published on the number of women that end up having a positive genetic test, even though they don't fit the criteria for testing. So as you know, not just here, but around the world, there have been data to suggest who should be tested based on subtype, age, family history. But we may be missing a lot of women who actually have a mutation because they don't fit the classic criteria. So we have now started to implement testing almost 100% women under the age of 65 that have a new diagnosis of breast cancer, regardless of family history, regardless of subtype. For women over the age of 65, we tend to have more of a discussion with them about who's left in their family, how much would it change what they do if they had a positive test.
Okay. And Patricia Marques.
One more thing. And I think the reason for that is because the cost of testing has come down dramatically, right? Because it used to be a myriad test cost $4,000 or $5,000, but now you can get an in vitro test for an expanded panel for almost $200. Yes. So I think it really does open up that opportunity. You're absolutely right.
In Brazil, we are using in vitro tests, yes, for $200. It's different because dollar here is too expensive now, but it's much better than 5 years ago that to test one gen was $1,000.
Yeah.
And we have another question for Patricia Marques. What about the follow-up in COVID reality? In this case of high risk local recurrence?
Yeah, so this is a good question as well. I think follow-up for patients, all patients, for example, I think there are different levels, different timeframes, like you're mentioning. So, for example, what about just a classic patient who was maybe going to get a mammogram for her yearly follow-up who had breast cancer 3 years ago? Those patients, we've been pushing 3 months, kind of a classic normal risk patient for follow-up imaging and exam would get pushed 3 months. But for the high-risk patients, we're still continuing to see those in normal follow-up. The real question is, what is a high-risk patient? So that's where you have to come up with your own ideas in your own clinic. And it may differ in your clinic compared to our clinic. We're trying to base it on things like neoadjuvant therapy with an incomplete pathologic response. So if patients had an incomplete pathologic response and they had a lumpectomy previously, those would be considered potentially high risk. So they would continue their normal screening, those types of things. So you're right. It's difficult. And this is where sometimes it's almost on a case-by-case basis, whether that patient can get pushed 3 months or 6 months, or should they have their follow-up at the same time. What's really important is that if you decide to have a follow-up of a patient, you want to make sure that they're not overlapping with, they're seeing medical oncology on Tuesday, then they're seeing the surgeon on Thursday, and then the following Monday, they're seeing the radiation oncologist. So now what you want to do is really streamline that to make sure that if they're going to have follow-up, make it only one person. So it's only one visit, if at all possible. And I think what's going to happen is it's going to actually potentially change what we do in the future as well. Because what we're realizing here in San Francisco is that maybe we were seeing patients too much, or maybe we were overlapping too much with the different disciplines. If the patient is seeing oncology every 3 months or every 6 months, do they really need to see the breast surgeon for the exact same question every 6 months? Maybe not. So it can help us streamline in the future, and that maybe we'll do things very, very different.
Yes. Michael, in Brazil, we really worried about because we have different scenarios. So in the same city like Rio de Janeiro, we have the public and the private scenario that are very different. And we are trying to the peak of the curve at the public hospital.
Right.
So our society decided to recommend not any universal strategy. Mm-hmm. We are trying to individualize the case because there is no prediction when will be the end.
Right.
And for us, we have many cases of advanced breast cancer.
Right. Very different.
So we are trying to see our patients again. We are trying to do our biopsies, and different from United States, we are trying to operate many of the initial cases because maybe in the 3-4 weeks, I don't know what happened with the hospitals, with these patients. So I think that for Brazil, today I read the Dana-Farber recommendations. We don't have money to test every patient with positive hormone receptor to decide if she will go to chemotherapy or hormone therapy. So my opinion about this is that we have to individualize. If your hospital has the security conditions to test the patients, the team, maybe it's time to try to do the surgery, because we don't know if this pandemic will last 2-3 months or 6 months.
Right. No, you're absolutely right. I think before the universal testing that was implemented just this last week, asymptomatic patients that were having surgery, we were treating them as if they were positive. So that patient, so all of our patients are not, I mean, and this is difficult, but all of our patients that come into the hospital, they cannot bring any friends or any family members with them. They come in by themselves. They wear a mask. They're in pre-op. All the physicians wear masks. We don't really touch the patient. We go to the operating room. During the intubation, everybody leaves the room. They get intubated, and we have to wait 15 minutes until we can go back in the room to start the case. And then at the end, after extubation, we wait 15 minutes before the patient is transferred out. So you're right. We did the best we could with what we had, and I completely agree with you. I think also, obviously, in the United States, genomic testing is much easier to get for patients here. And if you can't do genomic testing, then you'll just have to base those neoadjuvant cases on subtyping, luminal B versus A versus triple negative and HER2, for example. So you're right, it's very, very different at each place. And the last thing I'll say is that we also restricted the surgeons from moving from one hospital or to the other. So for example, I was operating both at the very public hospital and the university. When the pandemic started, I was told to stay at the university, and there would be someone who would stay at the public hospital, and we would not go back and forth to try to decrease the possibility of cross-contamination.
Okay. Pimentel?
You guys can hear me?
Yeah.
Yeah, sorry, I had bad times here with my connection. I think you have a couple of questions here. I think Michael answered this one before, but I'm gonna ask you again. It's about Dcis hormonal negative, Michael. You can postpone this case. You can answer this again, please.
Yes, so I think for the estrogen positive Dcis, it's pretty straightforward with anti-estrogen therapy, and there is pretty good data that would be okay to wait at least 3 months. For the estrogen receptor negative, we were typically, and still are, taking those patients to surgery sooner than later. Now, again, you can also look at this as a case-by-case situation. So if it's a 58-year-old woman with less than 1 centimeter of calcifications and it's ER negative DCIS, maybe waiting 8 weeks is probably not dangerous. But if it's a woman that's 42 that has 3 centimeters of calcifications, the chance of being upgraded to an invasive cancer is probably much higher. So that patient might want to go as soon as possible. So I think we were taking most of our estrogen receptor negative cases to the operating room as closer to not emergent, but urgent cases. The good news is that it's not that common, so it's not a lot of cases.
Michael, I have another question here. It's from Tozello, a friend from São Paulo. What your routine about the workup before surgery? Systemic staging? Only symptoms? Local advanced cancer?
Yep.
What is it?
In our situation, both before COVID and during COVID, is if the patient has locally advanced with a positive lymph node, then we would get whole body imaging. If the patient's lymph node negative at diagnosis, then we do not typically do whole body imaging. Unless, as you said, patient has specific symptoms that sound worrisome. So obviously, neuro changes, back pain that is new, something in that case, we would probably work that up. But in general, clinically lymph node negative patients do not get whole body imaging. Positive lymph node patients before neoadjuvant or before surgery do get whole body imaging.
What kind of whole body imaging you prefer? CT, PET CT?
Right, good question. So previously, I think it was more of just a reaction in the United States, and especially here, we would just order a whole body PET scan with CT, but it's very expensive. Now, most of the time, we're getting CT, abdomen, chest, abdomen, pelvis, and bone scan. And then only if any of those show something would we move potentially to the PET.
Any other question, Pimentel?
I don't know. I left for some minutes. If someone asks about the Patricia question, if you can postpone radiotherapy.
So, yeah, I think radiation therapy, it kind of depends on your radiation oncologist and how they feel. From what I understand in my radiation oncologist, the window of opportunity is probably in the first 10 weeks, maybe 12 weeks. And I think after 12 weeks, you start to lose the benefit of radiation therapy. That's kind of that's how we view it here. But I think it would be something to discuss with your own radiation oncologist about how they feel about pushing radiation out farther than 12 weeks.
Michael, another question about the CIS. Lincoln is question with if you use low dose tamoxifen for this patient that is delayed surgery, had a delayed surgery.
For DCIS patients?
Yes. Are you using low dose or the normal dose, 20 milligrams of tamoxifen?
Yeah. No, it's a great question based on that data that we saw in San Antonio, et cetera, about potentially every other day dosing or half dosing. I think we usually start with the standard dose. If the patient is having problems with tolerability, then we will decrease the dose at that point.
Okay. We are doing the same here in Brazil.
Yeah.
So I think that it was a great opportunity to discuss with Michael again. I hope to have you here in Rio soon as possible.
Or have you guys here.
Oh, okay. Would be a pleasure. It's one of my favorite cities in the United States. Thank you so much, Michael.
I miss seeing you guys. It seems like it's been forever. I hope we all get together and share more cases and experience, because every time I'm with all of you, and especially in Brazil, I learn a lot that I can take back to my own institution as well.
Okay, Michael. Thank you so much.
You guys, everybody be safe, okay?
Okay.
Thank you for joining us.
All right.
Bye-bye.
Thank you, Michael. Bye-bye.